Go ahead.
One of the things that we've talked about is how when you open, like, our emotions come up, it's kind of hard because then you start to fall apart a little bit. So I'm noticing yesterday was very powerful for me. I spent a lot of time thinking about it, and today I can't function. So again, which is good, right? I'm feeling slow. Okay. We're happy for you. So I want to say I've been really looking forward to this presentation ever since you agreed to do it. I think everybody here is really going to benefit a lot from it, and you're just so humble about what you've done for the world with this work, and so I just want to say that, like, she's so humble, you guys. So Dr. Dube, Shanta Dube, is the director of the Master of Public Health program at Wingate University and has been a public health practitioner, researcher, and academician. Academician? That is the first time I've ever used that word. For over 25 years. She served as a social and behavioral epidemiologist for 14 years at the Centers of Disease Control and Prevention and has extensive experience leading major programs and projects, including research and national surveillance programs. Dr. Dube is an international expert on adverse childhood experiences, social determinants of health, substance use disorders, toxic stress, and resilience. The hallmark of her career is that she is a recognized expert in the area of adverse childhood experiences, where she continues to build awareness, acceptance, and adoption of the ACEs science. Thank you for all of that, and thank you for being here today.
Thank you so much. Well, I have to tell you, first of all, I want to just thank all of you for your service in keeping us as a free country, and I'm humbled to be in your presence because the work that you do is extraordinary, and I couldn't even begin. I mean, there are no words, honestly. My nephew texted me this morning, "How's the conference going?" I'm like, dude, it's like this most powerful, amazing experience, because he knows about my ACEs work, and he is an addict. He is a recovering addict with his own traumas. So I told him about the conference and all the different stories and presentation. He goes, "Wow, that sounds just amazing." It puts things in perspective for me personally. So I want to thank Jamie and Dr. Roberts for the opportunity, because I don't feel like there's ever enough opportunities to meet sometimes. So I appreciate it. And today the focus of my talk and some of the studies I'm going to present is understanding the impact specifically of childhood verbal abuse as a form of moral injury. I don't have a lot to say about childhood verbal abuse as moral injury, because here's what I'm going to say. I have learned this week that I don't really know as much about moral injury as I need to learn or know, and I'm learning a lot. So I would say and invite us after this presentation to have a conversation, and so we can learn from each other about how verbal abuse and ACEs are a form of moral injury, so we can really understand each other's perspectives, if that's okay. So before I start, we're in this beautiful retreat center. I told my sister about it, my oldest sister, and this is actually the closest I've ever been to that. How many of you have heard of the Bhagavad Gita? Okay. So Bhagavad Gita is a song of God. It's the segment of the Mahabharata, which is a classic epic in Hindu philosophy and mythology. And it focuses on two cousin families, the Kauravas and the Pandavas. The Kauravas are representing lust, greed. Pandavas represent righteous, dutiful family, but they're cousins. And Lord Krishna, who is one of our deities, he mentors his devotee Arjun, who is this exquisite warrior. I mean, he was born into life to be a warrior. But the dilemma Arjun faces is he's on the battlefield, and you can see in this picture all these people. He has to fight against his own again. So And he is on the battlefield, 39 million on the battlefield, and he falls to his knees and says, I can't kill him. I can't do it. So Krishna steps in and says, this isn't what you were brought into this world. You're a warrior. And basically what the Gita is while it's about the Kshatriyas, which are warriors, on the battlefield, it's really also that battles that we kind of face for ourselves. Like somebody showed a video yesterday, the guy tussling himself. Yeah. Similar. So I just want to give you a little bit, and I'm not trying to ridicule the battlefield. This is what my faith, this is what the faith I follow. So I wanted to share it with you. It is universally renowned as a jewel of India's spiritual wisdom. It is an ancient text 400, 200 BCE. And what it teaches us, every word, every chapter, teaches us the morals and ethics, including the importance of performing one's duty without the attachment to the results. So the Gita emphasizes the value of moral integrity and righteous action and encourages individuals to lead virtuous and ethical life. So one of the key things I hope you take away is, so Krishna is coaching his very close to his devotee and close friend, that's what he calls Arjun. Arjun's listening because he's got so much faith and devotion to Krishna. And throughout the Gita, he tells Arjun, this is what life is about. This is what you have to think about, your duty as a warrior, as a Kshatriya, to, yes, your kinsmen will die, but this isn't the end of the life, because the soul doesn't die. The soul keeps transversing into different bodies. So that's the story. And then I want to share with you what happens is Krishna is actually Arjun's charioteer. So he is riding the chariot, Arjun's in the back, fighting his kin. And what this chariot represents, the chariot itself is the body. The 5 horses that lead are the senses. The ground, the field, is the object of the senses. So that whole battlefield. The reins are the mind. To think about what you do. Horses, I'm allergic to horses, but I've been on a horse. It's about being able to steer that horse. So the reins are the mind. So how do we control our mind when the senses are running endlessly? And then Krishna is the intellect, buddhi is what they call it. And Arjun actually represents the individual, Atma means soul, the individual passenger. So as we go through the many different things we do in our lives, the different battles that we fight physically on an actual battlefield or in our personal lives or within ourselves, we have to keep in mind, where are our senses going? How are we able to control our minds? And where is our intellect? Is our mind taking control of our intellect? We all have this. We're all capable of actually learning how to bring calm to our mind, to our senses. It's not easy. It's not easy at all. But that is the story of the Gita. So I wanted to share that with you. Yes.
That one sentence is like really rocking my world right now. Doing one's duty without attachment to the results. Like I don't even know what that was.
Giving up the fruits of the action. You do what's the best in your hands and then give up the rest.
That's
not
hard.
That is the lesson.
But that's really freeing for me to hear that, because I'm a fixer and you can't be a fixer. That's not what we're called to be. But if you can just give and share what you're given, and then allow the spirit to work on people, and like instead of being Okay, I failed because I don't see any results.
Right,
Right?
yes, yes, the fun part of it.
That's what, so that, and it's hard for me too, like in everything. But if we can have that faith, whatever faith you follow, doesn't have to be, whatever. Yeah.
And so-
But that's universal, I think
It's
that's.
very universal, it's the beauty of the, I'm not trying to.
Yeah.
It is universal, it can apply to any.
No,
It's universal, you know.
But in chapter 17, verse 15, I mean, it's 18 chapters. I just want to share this. Again, he's teaching Arjun about all the morals and ethics. He says, austerity of speech consists of speaking words that are truthful, pleasing, beneficial, and not agitating to others. So everything you would read in the Gita, a lot of this actually uncovered some of this in recent years. So thank you for letting me share that. The objectives of my presentation today, so now getting into epidemiology mode, is to describe the burden of ACEs and childhood verbal abuse in the population, explain the outcomes associated with childhood verbal abuse across a lifespan, and then discuss how childhood verbal abuse is a form of moral injury, and that's where I think I want to engage everybody in the room. I don't know how many of you know Sandra Bloom. She's a physician, well known in the trauma field. But this is her quote, and I present it all the time. Average childhood experiences studies are as revolutionary as germ theory was for the 19th century. Just a little bit of epi for all of you. On the right side are the leading causes of death in the US, ranked 1 to 10, 1 being the number 1, 10 being the 10. COVID now is in there after 2 or 3 years of death certificate data. But I'm highlighting this because it's important to understand how the ACEs study started. How many of you know how the ACEs study started? Some of you do. So it started the National Center for Chronic Disease Prevention and Health Promotion at CDC. And it kind of was influenced by what we knew about the actual causes and leading causes of death in the US. But what the ACE study was really trying to uncover, and the research question behind it was, what are the underlying factors that contribute to the actual leading causes of disease and death in the US? So now we're going to jump into the science of childhood adversities. Anybody know who this is? This is Dr. Vincent Belletti. He was one of my mentors on the ACE study. And he was actually the main face of ACEs because he made the discovery at Kaiser Permanente in San Diego. Basically, he ran the Department of Medicine in San Diego Kaiser and had a weight management program set up. He was referring patients who needed to lose 40, 50 more pounds because they were at risk for metabolic disorder. And while they were successfully losing weight, they were dropping out of school. Makes sense of it. Like, what's going on here? So he brought each of them in for an interview, in-depth clinical interview. And through those interviews, he also did a case control study. You see the citation on the bottom, that predates the ACE study. That was, those were his first clinical discoveries at Kaiser. He found that these women who were dropping out were starting to be approached by men, were being complimented. It was making them feel uncomfortable, so they didn't want to be in the program. He learned through those in-depth interviews. I remember talking to him. He's like, I thought I was interviewing the same patient over and over because I kept hearing a recurring theme of molestation, sexual abuse, sexual assault, verbal abuse, substance abusing parents. And he learned that, oh gosh, this is a trend. And that's why he published that study, which was picked up by the CDC. And then that's how the ACEs study started. But some of the things I will never forget after from Vince is and I went to his weight management program. I sat in them. It's not about how people become overweight, it's why. What is the underlying? I remember telling him, oh my God, these destructive behaviors, and he immediately corrected me. He's like, no, we're not calling them destructive behaviors. These are risk behaviors that are solutions for these individuals. They're normal reaction to abnormal circumstances. And so actually he took his findings and revamped the whole weight management program. He integrated a life timeline. So, and then when you talked about your genealogy, that's one method, but another method is using a life timeline to understand health issues and other issues and understanding what was going on at that time when the health issues started. He integrated that. And one of the questions that they go through is, when did you first start gaining weight and what happened during that time? And I sat in on those groups, and it was an epiphany for me too, because all of them had an aha moment about their own health and well-being. So the original 10 ACEs, and I alluded the other day, this is going to change in a few months based on I worked with the CDC on a funded project over the last year, just finished, but these are going to change. I can't get into it, but there's been a human outcry to reframe ACEs for the field. But these are the original 10 that we examined. 3 forms of abuse: physical, emotional, sexual, physical, emotional neglect, and 5 household challenges. Now, back in the day, we used to call it household dysfunction. That term has changed, that has evolved. We are calling them household challenges or related household stressors. Why don't we call it dysfunction? It's to it's kind of demeaning in a way, if you will. It's judgmental. So those are the 10 ACEs we examined. Today's talk is primarily about emotional abuse. I wanted to give you a snippet of the estimates from the Kaiser cohort. So we found, and this is between 95 and 97 that the data were collected, 28.3 reported physical abuse, 15% reported emotional neglect, and then substance abuse has been an all-time high across every year, decade, every state, every population. Substance use or abuse is the highest prevalence as far as the household stressors. We also created this very blunt score called the ACE score, and it's a way for us epidemiologists to establish dose response relationships, because it helps us to establish causality between risk factors and outcomes. So this is the ACE score, and I say it's blunt because it's just an integer count. Doesn't take into account when the abuse or the ACE occurred. It doesn't take into account how often, how intense, how frequent. So, but the key thing to know is that 64% reported 1 or more, and 37 reported 2 or more. And this was an aha moment for our team, because we realized you can't look at abuse, you can't look at neglect, you can't look at anything without understanding the full spectrum of what's going on in the childhood environment. And I'm just sharing one of the outcomes from one of our studies. We have a lot of publications, as you all may know, looking at ACEs and multiple outcomes, not just mental illness, but we also, I published a paper on autoimmunity. So you were talking about autoimmunity yesterday, and this is specifically on emotional regulation, and I'll walk you through what this is showing. Amongst the adult cohort, 17,000 adult cohort, adult members who, private members who took part in the study, we assessed their ACEs, and this is that blunt instrument, the ACE score. Total. And then we also asked them in the questionnaire they were sent to their home, what is your general level of perceived stress, and what is, how difficult is it for you to control your anger? And so all this is showing is that dose response relationship. The more ACEs, the greater the likelihood of reporting difficulty controlling anger, and the greater likelihood of perceived stress. Mm-hmm. So I'm highlighting this because I'm going to show you some more data, but I'm highlighting this because we all have stress. But what we're showing here is that ACE is an underlying factor that can create scenarios in our body, our physiology, our stress response, that when we are faced with something, we are constantly in trigger. They're reactive. 6 years, or no, sorry, about 10 years into the ACE study, our leadership was like, gotta do something else here, because everybody knows how ACE is, or most everybody, but they want to know what are you going to do about it. And how are you gonna apply this to public health? So myself and a couple of the team members, I actually took the lead, but the BRSS, Behavioral Risk Factor Surveillance System, how many of you have heard that? Okay, so in public health, our patients are communities and populations, not individuals. We rely on data. Epidemiologists, our sole task is to utilize data at a population level to understand the distribution of risk factors and disease in populations so we can do targeted interventions. It also helps us to understand the lay of the land in terms of the population health and gives us a pulse check. So the BRFSS is in the Chronic Disease Center at CDC. National Immunization has their own surveillance to assess infectious diseases, immunization rates, etc. It's just how CDC works. It's our bread and butter in public health. So in 2010, I suggested let's get an ACEs BRFSS module going. It's a state-based system, so CDC works across each state and works with them to collect data on specific indicators related to chronic disease, even infectious disease. It is a self-report random digit dial survey, and it's been going on since the mid-80s. So we had an opportunity to develop the ACE module in 2006. We proposed it. It wasn't ratified until 2007. At that time, I left and went to the Office of Smoking and Health. But in 2009, these were the first states to implement it: Arkansas, California, Louisiana, New Mexico, Tennessee, and Washington. And then by 2020, 28 states had implemented it. And now what are we, 2024? We have close to 40 states that have implemented it. It provides population level estimates in data representative states. And I'm just pointing out, one of the items on the BRSS is emotional abuse, right? That one ACE. This is the item that it asks adults. Did a parent or other adult in the home ever swear at you, insulted, or put the respondent down? So the person on the telephone asks the respondent this question. I want you to be mindful that it's termed emotional abuse. That looking at the face, what we call face and content validity of the item, what does it really measure? Like, what does it really measure? What? Verbally. So let's see what your states look like. So this is my state. I think there's somebody else here from North Carolina. So this was in 2012. And while this data might seem a little old, I want you to keep in mind I'm going to show you some other data. They haven't changed over time. So emotional abuse in North Carolina was reported at around 29%, but these are all the ACEs. Neglect. When I developed the BRSS in 2006, we couldn't include neglect due to person time burden. So those items aren't included in this, but they have since been added to the 2021 BRSS. So now they have all 10 ACEs. But these are the 8 ACEs. And then in North Carolina, adults, 58.5% of adults report 1 or more ACEs. So I present this to the health profession students at Levine College at my university because they all have to go do clinical rotations. And my goal is to bring awareness to them about, well, this is the burden of ACEs, potentially the burden of ACEs in patients, adult patients you're going to encounter. Then I just highlighting some outcomes in North Carolina. Again, these are these dose response relationships. As the ACE score increases, so does the absolute risk of each of these outcomes: smoking, heavy drinking, binge drinking. Sorry, the labels are a little skewed to the left. And then we started looking for everybody else's state. So we have 2 Arizonians here. And these are the prevalence of ACEs. I'm sorry, it's a little small, but I took it straight from Arizona's website. 35% of adults in Arizona report, and here they call it verbal abuse, regularly, right? But you see the term they're getting on, we're going to talk about that. 30% reported parental separation, 24%, 1 in 4. Drinking problem in the household. That, I'm telling you, that estimate has not changed over time. But I highlight that verbal abuse is higher than sexual and physical abuse. That doesn't mean that that does not occur. It just, there's been a lot of campaigns and efforts to prevent and educate on those two forms of abuse.
I have a quick question.
Yes.
So, that's a pretty hard number for divorce and separation. And do you all take into account for like, what if it's a better situation for, like, what if there is abuse in the family and then there is a divorce because of that? Like, does that still create a basis for the?
It does.
It does.
So that's how the original ACEs was conceptualized. But again, there's going to be changes forthcoming with the Division of Violence Prevention's new framework, because there was a lot of discussion that perhaps parental divorce isn't necessarily an ACE. I argue that it is. I think anytime a nuclear family breaks up, even if there's abuse, it's part of the whole, if you will, spectrum of what's going on in the childhood environment. So yeah, they're being abused, now they're being protected, but now the family is split up, and I think can be a traumatic experience. And that
Well, and in divorce, even though they will have one home if there has been violence,
doesn't have to.
that is safe. Because custody generally, it's very hard to not have the kid have to go to that house. Now there's no protection.
Yeah.
Yeah.
And then if you add a step parent to it, then you double down. So I definitely don't want to see that change because it changes the economy of the family.
I agree.
Right there, that's just, even though you may be safe, you're now poor, now both parents have to work, there's no one at home, like it adds a layer where one factor is better, but it's like, do you want your hand or your foot to be cut off today? It's one of those decisions.
There were some heated conversations about
Yeah.
that last year, and I was pushing to keep
Good.
it.
Yeah.
Not only that, because of the changing demographics in our country with immigrants. You know, some of the group center, somebody talked about group center, cultural,
Yeah.
I think we should do that. Well, Asians are also group centered, and so when it's traumatic I think it's traumatic all around, but I think that in some cultures, even more so just because of the nature of, the stigma.
Yeah.
But then, I think that the struggle is with that kind of situation is then you're damned if you do, you're damned.
That's exactly right.
That is
It's
true.
getting it from the mind of the child, right? And I
Who will question you why you didn't leave that situation later. And
exactly. And so I can divorce the person and get away, but my kid never quite gets away. So you have to factor it in. It's a both and, not an either or, and that's the reality of it. It's just it's sad that our pickers are broken.
Yeah.
My lady picker, my man picker is broken. Now I put my kid in a moment that, yeah, right, it's no win.
Yeah.
Natasha talked too, though, that it was really hard for her to remember because she couldn't protect her kids. If she did leave, and she finally did leave, and then she felt
It's a
so.
difficult situation.
Yeah.
Well, there's no easy answer. It's gonna be hard no matter what. So it's adverse if you do and adverse if you don't. You're absolutely right.
Yeah.
There's no way for it not to be adverse because the situation sucks,
Yeah.
That's it.
no matter what.
So, we can have more conversation, let's make sure I get through. But this is the Arizona BRSS still, 2014, and again, showing these strong dose-response rate relationships in the state. So these are representative of adults in Arizona. That's what I want to point out. So poor health, heavy drinking, current smoker, asthma, and these are physical. These are physical, and then mental distress. I'm sorry it's so small.
It's okay.
We can see the.
We don't want to see how bad a blackjack is there, but here it's bad.
You have lots of work.
Yeah. John's good.
So, study by actually Elizabeth Suedo at Division of Violence Prevention, who I worked with on this new framework. She heads up the BRPSS. So the BRPSS, the ACEs stuff was in the chronic center. All the ACEs stuff moved over to the injury center, internal politics. So now it's housed in the Division of Violence Prevention at CDC. But anyways, they did a study, and I highlight Nebraska and Louisiana. I don't have all the ACEs here because I couldn't fit it, but we can also go to the publication. But I just want to point out emotional abuse. Again, they're calling it, CDC is calling it emotional abuse. So 30.7% in Louisiana and 33.7% in Nebraska.
We'll try more.
Yeah.
He's been hanging out with us a while.
And then finally, South Carolina, somebody else is here, oh, Rebecca's from South Carolina. I'm trying to make this a little, like, I'm sorry I didn't get everybody's states, but, I think you get the idea. In South Carolina, these are the prevalence estimates in the adult population, again, representative of the South Carolina population, and 30% rate report emotional, they call it. Some of the states are calling it verbal, and some of the states are calling it.
What do you make when you're looking at these, when you see, like, it seems pretty consistent, 30%-ish for the emotional.
I'm gonna talk about
the difference between the mental health,
Yeah.
16 and 1,000% in Arizona.
This is growing up with mental illness.
Oh.
These are ACEs, so this is what happens in the
Gotcha.
adult's childhood environment.
But then in the Arizona one, that's it's the same number, but look at what do you make of why it would be so different? It's a giant difference between the two states. Arizona's mental illness was very high,
Well, so
or is
maybe,
it mental
No,
distress?
16% mental illness among adults. So
Gotcha.
someone who's depressed, mentally ill, or suicidal.
Okay, so it's the next slide over that's sort of,
I think,
no, I'm sorry, go back one. See on the far right, no, go to the next one.
This one?
No, the one that's Arizona, that was so small, that one. See on the far right?
I think I
These
understand it.
These are the outcomes.
There you go.
This is
That's,
outcomes.
there you go.
Each of these bars represents a number of days.
but that's how the person feels,
Correct. This is the adult outcome.
living, not growing up.
This is the adult outcome, mental distress.
Based on
Their
the
ACE
base
score.
gotcha. So some of those don't reflect that slide of the ACE outcome. The other ones are the reflection of the scoring.
Correct.
Gotcha. Okay, that's fair.
So these are this is
Yeah.
how it manifests in adults.
Yes.
Correct.
Question.
This is how, I would need an hour and a half to present the whole ACE study, and I just didn't have enough time, so I apologize. So these are just prevalence estimates. That means the total number or the percent of the population that reports a particular ACE. So this is emotional abuse in Louisiana, Nebraska, and South Carolina is 30. So they're all around 35. Some states have a prevalence estimate of emotional abuse of 40. There was another study by Blossnick et al. Using the BRFSS data to examine what does ACEs look like in military history versus no military. And not surprisingly, it's quite high in the military, but we've been talking about that all week, right? So, and then in particular, and they're calling it emotional abuse, 43% of individuals with a history of military report being emotional abuse during childhood. But I will also point out here, only 26%, that means close to like 72%, 70, if they my math right, 74% report at least 20s. So this is a history of military service. Versus more like 60% in the civilian population.
So this to me shows the classic story that a lot of us have in this room of joining the military for fun. Right?
Right.
Of us
Get
growing
away.
up and saying, this was hard, we want to do something different. So this just reinforces all the stories that you can get from all of us.
Absolutely.
As a sample and like in aggregate too.
Yeah, exactly. I just wanted to share it with you.
Yeah.
You know the screen.
I know.
Like you see it, you're like,
Yeah.
oh, this sucks.
Yeah, it makes me want to.
I'm not trying to make it stop.
I'll go with you.
Let's let her talk because it convolutes the sound quality.
Here's what we know, and Annette alluded to this yesterday, growing up with ACEs impact the developing child in ways that we don't see. Pediatrician can do a swab and say you've got strep. Pediatrician can look at you and say, oh, you've got measles, mumps. Pediatrician, unfortunately, cannot see the endogenous stress response in kids who have been exposed to ACEs. It's just the only way they can really see it is by behavioral difficulties, and that is something that's getting a lot more attention now, especially in the school system. So we talked about this, these experiences often go unrecognized. They go unsubstantiated. What do I mean by that? Most abuse cases are not reported to the CPS. And so there's a large proportion of adults who have endured, suffered, and are thriving from their ACEs or abuse experiences. There's a lot of stigma and secrecy, so people don't talk about it. So what does that do? You keep bottled up, and then what happens? Yeah. Emotional abuse or verbal abuse is one of the most unrecognized forms of moral injury. Why? Because often you can't, first of all, and I work with the CAC, the Child Advocacy Center in North Carolina. They have methods to diagnose sexual abuse and physical abuse. They know that verbal abuse is comorbid, but there's no way to substantiate that. So what gets said behind closed doors is rarely heard or known or seen. And often the individual has to live with the words a lot. Yes.
Talking about unsubstantiated, and I was just talking with this meeting about this, a lot of times, never mind that there's people who don't, not saying never mind like that, but there are people who won't report. There are some who can report and nothing is done.
Sure, absolutely. But they're still unsubstantiated. They don't make it, right?
So that's moral injury.
That's
Right.
right. Yeah, that's a great person.
They're doing more injury plus the system.
Absolutely. Thank you. See, thank you for saying that, because I'm working on another study right now looking at the NCAN, which is a database of substantiated cases. And I think that's important, like I'd like to add some language, like there could be cases that aren't reported and that can lead to moral injury and meaning, this is why this dialogue is really important. But I'm learning that reported would be a form of moral injury. So let's get to the topic at hand. There are 4 actual subtypes of child maltreatment recognized: physical, sexual, emotional abuse, and then neglect. Of the 4, emotional abuse is the one that has the least studied, and yet it's the most prevalent form, as you see in this data. Currently, how it is termed does not fit how it is defined in research and in practice. So now I'm going to give you a report. I gave this, sorry. But as an epidemiologist, looking at all that BRFSS data, I have said to myself, there have been epidemiologic shifts in this. And what that simply means is, at one point, physical abuse and sexual abuse had a very high occurrence in the population. But due to prevention, better recognition, awareness, those 2 forms have gone down. They don't not exist. It hasn't been eradicated by any means, but they have gone down over time in terms of their prevalence. Emotional abuse, on the other hand, across different data globally has increased. And so I highlight US adults, and I also highlight US adolescents. And so each bar represents a form of abuse: emotional, physical, sexual. Emotional is the red bar. And I want to demonstrate how, if you look across the abuse categories, emotional actually has the highest burden in the population. Yes.
So there's a question from Elizabeth online, and she says, emotional abuse is a vague term that seems difficult to measure. There's a difference between swearing at your spouse and nonstop swearing, right? So how do you measure the moral injury? Number of outbursts per hour per day, like that kind of thing, or how do you?
Well, I defer you all on that. Like, moral injury for me, as I've been talking to several of you, is, for example, seeing something happen but not reporting it. Or, is it actually the moral injury that those words, impact me if I'm told that I'm stupid and dumb and ugly or whatever, people said. What is the moral injury? Is it moral injury?
So to me,
Is it the moral, the moral compass that, oh, I didn't do something, or I didn't say something about that when I knew I should?
I think, to me, the difference is, I think if it's a one-time thing or it's a rare thing that, say, you swear at your spouse, that's going to bother them. That needs forgiveness. That needs to be talked about. That's wrong. but you can work through it. But if it's nonstop, it's a constant beat down. There's no ability to like, it's sort of like if a thing happens, boom, it happens, you go down, you can begin to work back up and get back to a place of, I'm sorry, that was wrong, whatever. But if it's constant, you stay in this valley and you begin to believe that, you begin to believe you're no good, you begin to believe you're whatever, and you lose the ability to work back up. And so it's like death by 1,000 paper cuts kind of thing, or death by 1,000 cuts, whatever that expression is. You can't heal to a point where then you just lose the ability to heal is kind of way. I don't know that there's literature to necessarily support that as moral injury is constructed, but our research with spouses shows that a lot of it was really based on numerous events, not one, really traumatic one.
Okay.
That's the best way I can work with that right now.
I think that the moral injury, I think your question, and tell me if this is an answer you might have been wondering, what is the moral injury? In the category of other to self, that the person that is vowed to, as a parent, either support me, lift me up, not say basically cruel things, whatever. It's a violation of the code of the protection. It's a violation of the family ethos, the family ethic, that. So I think it's other to self. I think spouse to spouse, you can probably do the same thing, violation of our vow. And I think, and I've got a wondering, we can offline chat, but in a way to collect data, I wonder if you could have clinicians, because I do Lifeline from birth, we chatted about that. So I've been doing it for more than 25 years. I've got data and I've got details. And so what I'm wondering is, I think clinicians who do such things will have exact quotes and exact data, covert and overt, verbal and emotional abuse, and we can qualify that, because I ask that question and then I get examples. Could we use that for your data? Because now you can collect it from the source.
Absolutely. And I do want to say thank you for bringing up covert and overt. This, what I'm presenting today is overt.
Mm-hmm.
There is covert, and I am working with another advisory group panel where the researcher focuses on covert types of verbal abuse or communication. So I thank you for bringing that up. This is really not overt, like the words spoken and the way they're spoken.
Could you give an example of covert then?
Yes. Covert, and Annette, you can jump in when needed, is like body language, is eyes, is not saying demeaning words, but insinuating this demeaning words. Sarcasm.
Yeah, withholding your affection.
Withholding
when it's obviously there, chronic lateness, put downs in a public environment where, oh, she's so, it's like a teasing, but it's not in your face, cussing. It's got it's acidic, but underneath, yeah, it is. It's a power grab and it's a hurt, but it's a little more undercover.
Yeah.
So you got about.
I know. To get the last slide. Can I keep going? Sure, please. What was the question?
Well, so where does, on emotional abuse, if there's someone who throws things in the house all the time, what is that? That's not physical abuse, but it's scary.
Intimidation.
What was it? Intimidation. I have a slide on that. So I'm gonna get through these data slides. This is just to show that emotional abuse is on the rise. That's all that is. Okay, so here are some positive reasons we see increases in abuse, in emotional abuse. We see less recognition. It's serving as an alternate outlet to physical abuse potentially. These are potential. There are various ways emotional abuse is termed and examined and measured in research, which makes it very confusing. But the real crux is childhood verbal abuse. Overt verbal abuse hasn't received the attention that the other abuse categories have. So these are some of the other terms you'll see in the research or maybe even in practice. childhood emotional abuse, emotional violence, emotional maltreatment, psychological abuse, psychological maltreatment.
Dr. Dube, sorry, you have 15 more minutes. I totally
You're good, 15
lost track of the time. So yeah, you've got 15 more minutes.
15 seconds for 15 minutes.
Okay, great. Okay, and so Annette alluded to this in her talk, talking about even in neuro, the child, everything is nonverbal for the child, right? But here's the key thing. The sense of hearing is the first sense to develop in the last trimester of pregnancy. So I heard the first day I was here, Raven talking about how she talked to her baby while she was pregnant. And I'm like, there's a program called Talk With Me Baby, and it's specifically designed to interrupt the intergenerational transmission of lack of literacy. And especially in particular in low SES, African American Black families, and I did this work when I was in Atlanta. So there is natural programming to help parents to understand the importance. So important. It impacts education, social, and emotional development. Verbal cue words are communicated that can have immediate impacts. Here's the other thing to keep in mind. We talked a lot about brain development, and 28 is the magic number. Well, we know that it's mid-late 20s, but children are concrete thinkers. It isn't. They don't start thinking abstractly until adolescence, and maybe even more so higher order thinking and really being able to decipher until their late 20s. These substances, that gets interrupted. That, you know, they have that show Arrested Development. I mean, it's a comedy, but it's the truth. It's Arrested Development. And so when somebody verbally says, when a parent says, "You're stupid, Johnny," Johnny doesn't know. He doesn't, his brain's not ready to say, no, maybe I'm not. I'm stupid. I'm dumb. When teachers or coaches, "Come on, John, get, you know," whatever they scream. I don't even know. I'm not even. Why can't you be like Jamie and get an 100 comparisons? That's all Johnny can think is, "I'm not smart enough." And somebody mentioned that during the course of the week, of like really thinking, and it becomes a self-fulfilling prophecy. Like you take it in and you believe it. So abstract thinking occurs much later. The prefrontal, as we know, isn't developed till mid to late 20s. And the important thing with this work is it's parents. Now, the parents have the primary contact, but it's all adults in contact with children. So I mentioned the child welfare system recognizes that child verbal abuse is very much prevalent, but there is no forensic method to establish substantiated abuse. What did I do? So verbal abuse versus psychological or emotional abuse. This is the paradigm shift I want us to think about. The speech behaviors of adults, such as screaming, harsh, denigrating, threatening words to children, is childhood verbal abuse. The result is children having psychological emotional abuse. And I'm going to tell you why it's important to distinguish that from a framework. Children, therefore, suffer emotional and psychological abuse, or even adults suffer emotional and psychological abuse through the actions of harsh speech behaviors. So when we think about primary prevention, which is preventing anything from happening, we have to think about childhood verbal abuse, because the only way to prevent verbal abuse is to educate and to help individuals to learn how to communicate effectively. If we continue to call it emotional abuse, we're then focusing on treatment. We're then saying, okay, after the fact, the damages occur, they become emotionally abused or psychologically abused, which is what they suffered. Now we have to go in. This is my biggest problem with how we are terming it. It's not effective for what we're trying to do in public health and really prevention. So this is just, I'm going to go through this. This was for the systematic review that we conducted to look at specifically child and verbal abuse. This was commissioned by Words Matter, a UK charity, and I'm on their advisory board. I just wanted to disclose that. And also in collaboration with University College of London. So just briefly, this is like the Prisma model, in case you don't know. This is a methodology we use to have the most rigorous form of doing a systematic review. At the end of all 13,000 papers, we came down to about 166 studies that we reviewed. And we didn't do a meta-analysis, we just did an evaluation of all the studies. So all kinds of terms were used to gather those studies, but when we actually reviewed the terms, no matter what measure they were using or what they were looking at, verbal abuse came up over and over and over. And in fact, emotional abuse was only used with other terms. What didn't come up as a term by itself. I'm highlighting this because right now, our field observes that a form of maltreatment is emotional abuse, but most individuals who are researching and practicing know it as verbal abuse. The other thing I want to share is what defines verbal abuse. This is overt verbal abuse. So these are, and it wasn't just parents we looked at in our studies. We looked at other caregivers, teachers, coaches. The speech behaviors that most were predominating is the tone through yelling and screaming. So very loud voice, criticizing words, threatening words, name calling, verbal put downs, swearing at the child, murdering, witheringly contemptuous remarks. Someone said, I wish you weren't alive, or I wish I never had you. And then from teachers and coaches, much of the same, maybe not as much of these types of harsher words, right? Then we've been focusing on these long-term outcomes, right? But one of the things we learned from this systematic review is the immediate impact to children and adolescents. Hearing things like they feel a loss of love, feeling loved, feeling hated, feeling rejected, feeling emotionally harmed, feeling overpowered and controlled. That was the immediate response. Now, can you imagine all the work that, and then all of you who work with the military, if that's what they experienced in childhood, the impact it has going into adulthood, and then to be cornered by it again as an adult, the kinds of re-experiencing that may occur. So I think that was a stark finding in our systematic review. And then, of course, as we know, there are lots of long-term outcomes starting in childhood. We looked at this across a lifespan in childhood, adolescence, and young adults and older adults, but primarily just what we've been talking about, depression. In children, it was slightly different. It was more behavioral, conduct disorder, frustration, bouts of anger, emotional dysregulation. In young adults, we found outcomes in our review of depression, emotional problems, alcohol use, them themselves engaging in interpersonal violence, and then mental illness, psychiatric disorders. Yes.
So one thing that strikes me is that, you grow up in a home with a lot of verbal abuse, then you go to basic training. And
Well, that's what I haven't been able
Right.
to wrap.
so, but here's the thing. So I grew up in that kind of household, right? And then I go to basic training, but I expected it. One.
So there is a learned.
So I expected that from drill instructors, and I would feel cheated if I didn't get it. Two, it's for a purpose of training, right? And three, there's a difference between a drill sergeant saying, you're a piece of crap, and yelling at you for, that's not how you do it. This is how you do it. And then as you begin to achieve success, this is just me, as I began to achieve success in basic training, because of the drill sergeant's instruction and training, then I began to feel better about myself. I developed lots of self-confidence. So I think a lot of it has to do with not the volume necessarily of one. It's, to me, I think it could be the relationship you have with the person, right? So a dad is supposed to be caring, nurturing, as well as developing. A drill instructor, you don't expect that from them, or you don't know what the military is about. And two, it's, again, like a drill sergeant that gets in your face and says, you're a piece of crap. That's demeaning. A drill sergeant that gets in your face because you did something wrong and he's trying to develop you. And the words he uses, the volume might be loud, but the words he uses are developmental. I think that could be a difference.
That's fair. I appreciate that. But what about when you're in, in a situation and you're working hard, and I'm not talking about the drill because that is a form of training, but
Right.
other types of work.
Oh, absolutely. In a day-to-day, like, yeah. Yeah. So I'm not critical of anything. I'm just thinking about how the differences manifest.
Yeah.
I also think it depends on the stage of your brain's development. Your dad has you when you're 0 to 8, and the military has you from 18, and so your comprehension and what people could expect of you to be able to process are totally different at that point.
Yeah.
Dan's question.
Everybody's seen this slide before. Everybody knows the different types of stress. Positive, tolerable, toxic. So ACEs are considered a form of toxic stress. Again, not seen, leads to the endogenous stress response. Everybody's seen this slide before? So this is we were talking about this yesterday. This is the baby's brain at birth. No neural connections. I think Annette alluded to between 0 and, it's actually between 0 and 6 that the most, because their sensory perceptions are like, everything, they're sponge. So this is their neural connections at 6. And then by 14 or 15, they prune. They take away the ones that the connections that they're not using on a regular basis. So there is opportunity, even in the face of adversity, to have positive experiences that build resilience.
Okay, absolutely.
And so the brain is plastic. Learning occurs throughout the lifespan. There's been fMRI studies to show that new neural connections can be made. However, it requires work. It's not just going to happen. Everybody know Bruce Perry's work? Dr. Bruce Perry's neurosequential model. It's the bottom up. It's called the bottom up. So basically, he says everything develops from the brain stem all the way up to the prefrontal. And what happens is, because of trauma that's unresolved, and in kids especially, they get stuck in their brainstem. So when they have those behavioral problems in the school, they aren't bad kids. They're just on fire. The brainstem is on fire. They don't know what to do. They kick, they shout, they scream, and they can't get to the other parts of their brain because their brainstem's on fire. Because that's where the stress sits and the trauma sits unresolved. Everybody know Martin Teicher, sorry. I had the honor of presenting with him last April on a webinar. But he has done some amazing work around looking at brain development amongst persons who were verbally abused. I can't even begin to cite his work, but he has some very key things that he says. He says it's actually important for clinicians not to jump to the conclusion that dissociative symptoms indicate sexual abuse. Verbal abuse in his research appears to be associated with a greater risk in dissociative symptoms. He has stated that parental verbal aggression was a sensitizing factor for traumatic life events across the lifespan. His research is focused on limbic irritability, and the ways he has measured that is through EEG. And he has shown that actually verbal abuse and verbal aggression, he calls it verbal aggression, is associated with all kinds of limbic irritability. What does that mean? It just predisposes somebody when they're in a heightened situation to be more reactive. And then I love this quote. by him. There are two components to verbal abuse. There's the criticism component and there's the yelling and screaming component. Both factors exert effects, but the criticism is more severe. Stress, weathering, and impact to systems. This came from the California Surgeon General's report. I worked with Nadine Burke-Harris on. She led it when she was Surgeon General in California. We had this table in there, and it's just documenting, if you will, that it's not just neurobiological development, but we see changes in immunology, endocrine, metabolic, and somebody said epigenetic. I think it was Dr. Archer mentioned epigenetic changes. I'm not going to go into the details of this because of time. So just a quick discussion slide. I just feel like right now we are very confused in our field and that we need to call it what it is, and that's childhood verbal abuse, because it's conflating things. When you're saying, oh, it's emotional abuse, well, that's what they're suffering from. And the other thing is I've worked with Childhood Domestic Violence Organization. Domestic violence, witnessing domestic violence can be a form of emotional abuse to children. So a lot of different camps call emotional abuse different things. So that's why it needs to be really termed what it is in terms of verbal abuse. I'm just gonna go through, these are my summary and recommendation. I do think that we need to get it on the radar of detection, because right now it's not really, because childhood emotional abuse is the key piece. The limitations of this systematic review, we may not have included all studies that were published. We didn't take into account cultural or country-specific contexts. The risk factors for verbal abuse were not examined. We didn't look at peer-to-peer, so like kids being verbally abusive to each other. So what does this mean for verbal abuse in adults? So this is that overt covert that we were just talking about. Well, silence is also a form of verbal abuse, and we're learning that because when a parent isn't responsive, it can border on neglect, but it can also border on covert. And these are just my thoughts on, moral injury and verbal abuse, going back to the Gita. Like, I make it a point to really be careful about how I speak to others. I haven't always done that in my life, by the way. Let me just tell you that. I haven't been the nicest person always, but and that's, I feel that moral injury that I haven't been the nicest person. And so now I always look at that verse, chapter 17, verse 15, and I really think, is it true? Is it helpful? Is it inspiring? Is it necessary? Is it kind? And I found this other quote in Ephesians: the tongue has no bones, but it is strong enough to break a heart. I'm going to skip all this, but can I just show a few more slides? I want to go into this. These are just 3 slides on this, Dr. Salutogenic. So we always focus on pathogenic. Pathogenic is, what is the risk factor that leads to disease? Well, Aaron Antonovsky developed the salutogenic, and he said, well, it's not either or. You're not disease or not disease, like what we do in epidemiology and public health. There's a continuum. And it suggests that even in the face of adversity, as humans, we have a capacity to learn and adapt toward health and well-being. It is a stress-oriented concept, but it focuses more on our health resources. What are our assets? What do we have? What can we do to promote our health, even in the face of adversity? So this has been a focus of my research. Is, okay, I did all this publications looking at the relationship between ACEs and health outcomes, disease, and many other types of negative outcomes. But we have a large proportion of adults who survive. 64% of adults have survived their adversity. So what's the deal? So I took that same BRSS data using the states. There's about 12,000 in this study who reported that they had one or more ACEs. So I call these trauma survivors. And I wanted to understand what are the factors that might promote their well-being. And in the BRSS, there's a question that asks about their past 30-day physically unhealthy days and their past 30 days of mentally unhealthy days. So we're seeing a dose response relationship, but it's inverse. So the individuals with trauma who reported cases, if they reported these evidence-based factors, physical activity, smoking abstinence, emotional support, and greater than a high school education, we found that they reported fewer. They had all four. They reported all four of those health promoting factors. They had fewer physically unhealthy days and almost on average a week of fewer mentally unhealthy days. My point is we've all survived traumas. What are we doing to take care of ourselves? You know, how are we promoting our well-being? There are a lot of things we can undertake in the face of adversity to really promote ours and others' well-being. So this was another study looking at healing and recovery in a community-based participatory research in Oregon. These are things that trauma survivors said would help. And so that goes back to the peer support. It's like really having that shared environment to be able to validate each other and talk to each other about experiences. I put the drugs and alcohol also used to cope. That's what the participants said. So this is solutophysiology. We're in this beautiful place, nature. I hope everybody's been able to watch the birds, get out. But this is what it tells us, solutophysiology. If we have high quality, responsive, nurturing, caregiving environments in childhood, it actually improves stress hormone reactivity in children. So these are where the positive childhood experiences occur, is creating that nurturing, supportive environment for kids. Having one or two adults they can talk to if it's not somebody in the home. They usually seek it out, but time in nature reduces the sympathetic nervous system activity that Annette talked about extensively. Meditation, yoga, the mind-body practices, the journaling, healthy sleep, moderate exercise has been shown to be effective for our immune system. Social support actually buffers stress-related cardiovascular reactivity. Positive social support. So that means we're not going to people who are going to be negative and kind of downplaying. We're seeking positive social supports. Diet. And then George Beatty is the one who did the study, but nurturing caregiving is associated with epigenetic changes. He did it in rats, but they have shown it in humans as well. They're showing that if we have that support, loving, caring, environment and relationship, it can actually lead to epigenetic changes as well. And I always put this up because I thought it was really cool. In 2018, New York Times asked their readers, what is going to be the greatest public health campaign for the next, I think, century or decade, and they said ACEs. So I'll stop. And I went, 8 minutes over.